Good afternoon to all of you on the East Coast, and good morning to you if you are on the West Coast. My name is Dr. Jose Leon. I am the Clinical Quality Manager at the National Center for Health in Public Housing, a project of North American Management. I want to welcome and thank you for attending today's webinar on how to recruit and retain culturally competent staff. This webinar is being recorded, and the links and resources will be emailed to you after the webinar has finished. At the end of the webinar, there will be a question and answer session. I would like to thank you. I would like to thank HRSA for allowing us to make this webinar possible through a publication grant number U30CS09734. I'd like to get started and introduce our speaker for today's webinar. The first presenter will be Darci Graves. She has over 10 years of professional and academic experience in the fields of cultural and linguistic competence, education, and public policy. A former faculty member at the University of Missouri, Kansas City School of Medicine, she aided in the development, implementation, and management of the diversity, spirituality, communications, and geriatrics curricula. She holds graduate degrees in communications, religion, and sociology and public policy. She currently serves as the Senior Health Education and Policy Specialist with the Health Determinants and Disparities practice at SRA International. As one of the senior members of the Office of Minority Health Think Cultural Health Team, she plays a key role in the development and maintenance of cultural and linguistic competency education and policy initiatives. With professional, academic, and volunteer experience in the areas of communications, religion, spirituality, race, ethnicity, language, sexual orientation, gender identity, and socioeconomic status, she brings a unique and inclusive perspective to the field. Our second presenter is Zara Marsellian. She is the CEO and co-founder of La Maestra Community Health Centers and FQHC, providing healthcare, enabling, and social services to help the underserved immigrant and refugee residents in inner city San Diego to become healthy and self-sufficient. Since 1990, La Maestra has expanded to serve over 40,000 patients per year in several areas of San Diego, including City Heights, El Cajon, National City, and Lemon Grove. Zara holds a master's degree in organizational management and has been actively involved in healthcare, education, community organizations, and other non-profits for over 25 years. I would like to have like a brief introduction for this webinar, and I would like to share some facts. By 2050, 54% of the population will be minorities, as the U.S. become more ethnically and racially diverse. There is a need for healthcare systems and providers that can reflect and respond to an increasingly heterogeneous patient base. The minority portion of the workforce is projected to double from 18% to 37%. There are 94,000 people working as healthcare educators and community health workers. 76% of them are women, 17% are black, and 18% are Hispanic. There are 80,000 healthcare practitioners, 75% are women, 11% are black, and 7% Hispanic. And there are 3,500 healthcare support workers. 88% of them are women, 27% are black, and 15% are Hispanic. I am now turning this webinar over to Darci. Good afternoon, Darci.
Good afternoon, Dr. Leon. Thank you so much for that introduction and those those introductory facts, because it's such an important part of why we're talking about this topic, but why this topic is so important and so relevant. Just from a technical aspect, I just want to confirm that my slides are in fact visible. I'm going to assume that.
Yes, they are.
Okay, great. Thank you, Dr. Leon. So as Dr. Leon said, my name is Darci Graves, and I'm the Senior Health Education and Policy Specialist with the Health Determinants and Disparities Practice at SRA International. And during the course of our talk today, we're going to talk about the importance of and how to recruit and retain a diverse workforce. Some of our learning objectives for today are to describe why recruiting and retaining a diverse workforce is important, to describe which elements which aid in the development of a successful diversity and inclusion plan, and to identify at least 3 techniques and/or best practices for recruiting and retaining a diverse workforce. Before we begin our discussion on why recruiting and retaining a diverse workforce is so important, I want to talk a little bit about terminology and concepts to ensure that we're all on the same page, so to speak. The premise for my presentation today, and I think is the underscoring importance of this topic, is that diversity and inclusion helps lead to innovation. And that equation comes through in a host of ways, which we'll talk throughout this presentation, and I'm sure that Zara will as well, about the importance of cultural competency and workforce diversity, and how bringing all of these variables together helps us to have greater innovation, have more creativity, and be more productive in the workplace. Now, when we're talking about workforce diversity, we're talking about a collection of individual attributes that together help agencies pursue organizational objectives efficiently and effectively. This is a very similar definition to of culture that we use in the development of and the publication of the National Standards for Culturally and Linguistically Appropriate Services in Health and Healthcare, or the National Class Standards, which is an Office of Minority Health initiative, which I'll mention a little bit later on in this presentation. One of the most important takeaway messages of my portion of the presentation is to remember that diversity or culture is more than just quote-unquote visible diversity. Culture can include characteristics such as national origin, language, race, color, disability, ethnicity, gender, age, religion, sexual orientation, gender identity, socioeconomic status, veteran status, and family structures, just to name a few. The Venn diagram you see on the right-hand side of your screen is a model that I developed many years ago when I was teaching at the medical school in Missouri. And the reason for the Venn diagram is to illustrate the overlay of all of these aspects of culture. Rarely, if ever, do we experience things through a single cultural lens, because we all have a race, a sexual orientation, age, gender, etc. So we all have multiple cultural lenses which we are looking through at any given time. I experience things as a white, straight, middle-class woman from Missouri. Because I am all of those things all of the time, I cannot tease apart my lens to look at things as just a woman or just as someone from the Midwest. This is just one of the reasons why developing the skills of cultural competency is so key, because you need to be able to converse with your patient, client, colleague, friend, and whomever to determine what cultural lenses they are looking through to help understand their point of view. Now, when we're talking about inclusion, we're talking about, what we're not talking about is assimilation. And I don't know if there's any Star Trek type people on the phone, but we're not looking at the Borg. We're looking at inclusion versus assimilation. So inclusion means sharing values as a collective while also being valued as an individual. In comparison, assimilation is the process by which a person or persons acquire the social and psychological characteristics of a group. We want to avoid any similarities to the Borg. The Borg take other species by force into the collective and connect them to a hive mindset. This act of assimilation entails, is not what we're looking for. What we're looking for is a culture that connects each employee to the organization, encourages collaboration, flexibility, and fairness, and leverages diversity throughout the organization, which can result in all individuals being able to participate and contribute to their full potential. Now, we talked about diversity plus inclusion equals innovation. And this innovation manifests itself in responsiveness to customers, relations with the surrounding community, an ability to cope with change within an organization or the greater community and entities. It increases staff retention and productivity, and it exposes individuals to new ideas. It helps forge mutual respect, increases one's business reputation, job promotion, and creativity. A diverse workforce has been shown to drive economic growth. It can help capture a greater share of the consumer market. Recruiting from a diverse pool of candidates can mean a more qualified workforce because you're thinking outside the box and reaching further than you may have previously. Diversity fosters a more creative and innovative workforce by bringing together workers with different qualifications, backgrounds, and experiences. They can all weigh in on effective and maybe new problem-solving techniques for aspects of the job. Businesses need to adapt to our changing nation to be competitive in the economic market. And as Dr. Leon already cited, that by 2015, there will be no racial or ethnic majority in our country. The development of a successful diversity and inclusion plan is a critical part of making sure that you are able to recruit and retain a diverse workforce, because it's not going to happen by accident. Unless there is a plan, it will be difficult to achieve the goals of recruiting and retaining this workforce. A diversity and inclusion strategic plan should be designed to create a culture which values trust and human dignity and provides the opportunity for personal development and self-fulfillment in the attainment of your organization's mission and goals. This slide illustrates some of the components that could or should appear in your hospital or organization's diversity plan: purpose and values, goals, objectives, organizational culture, training, education, recruitment, retention, and measures of success. It is equally important to note, though, that diversity and inclusion efforts should be included in all of the strategic plans, efforts, etc., that your organization produces. Diversity and inclusion should be avoided and should not be viewed as an add-on, but as a part of the process from beginning to end. The analogy I would use with college students is that this isn't a single course that you get to take and then mark off the list. History, check. Math, check. English, check. It needs to be thought of as a culturally competent history, culturally competent math, and culturally competent English. That said, today we are focused specifically on workforce elements in your various plans, so the following examples relate specifically to those issues. But the bigger picture should not be overlooked. This slide illustrates two sample vision and/or mission statements, and they come from the federal government-wide diversity and inclusion vision statement. To be the nation's model employer by leveraging diversity and fostering inclusion to deliver the best public service. And then the sample mission statement: to recruit, retain, and develop a diverse, high-performing federal workforce that draws from all segments of society and values fairness, diversity, and inclusion. So these are just two examples of plans or vision and mission statements that may be relevant or important to your organization as they develop a diversity plan. There are sample goals of workforce diversity, workplace inclusion, and of course sustainability, because as you're probably well aware, you need to ensure that once a plan is in place, that you are able to maintain the plan and that it is a sustainable one over time. Because very quickly, what once was diversity in action can become diversity in action. Because if an organization does not follow through on said plans, things cannot move forward. In order for a plan to succeed, change needs to happen from the top down and the bottom up. One should be thinking about all aspects of the organization as you think about diversity and vice versa. As a reminder, diversity is not a general education course you can just check off. Resources include money and funding, but also people and time. It is important to educate individuals about the importance of these topics and not just to give them lip service, and to engage individuals throughout the organization to review and develop appropriate policies. And as is with the mantra of most organizational goals and tasks, shared responsibility and individual accountability. Just like diversity isn't a single course, it shouldn't rest upon the shoulders of a single individual. And with everything, it should be measured, evaluated, and changed accordingly, and then repeated. So here are some techniques and best practices for recruiting and retaining a diverse workforce. We want to create an environment in which everyone feels safe, supported, and encouraged to express his or her views and concerns. Even before we enter what may be conceived of as the land of human resources, be thinking about, what do your public spaces in your organization look like? Do they show your organization united in its diversity commitment? What does the art say on your wall? What messages are communicated through your signage, through your posters, through your welcome messages? If one were to come into your organization in a wheelchair or through a different cultural lens, what would that look like or feel like to be that individual? In your messaging and your marketing, what images, what tone is used? What references, if any, are there to diversity and inclusion? Targeted media. Are the messages being put out to all of your possible audiences? Are you reaching out through community newspapers, key informants, or community leaders? Two-way communication mechanisms are critical with diverse communities in the service area. And finally, your virtual or web presence. Is there a diversity statement that is easily seen, or an equal opportunity statement? If someone were to click on the leadership section or staff section or your board of directors and to look at the images, what would they see? Would they see the diversity represented there as well? Recruitment. To design and implement strategic recruitment and outreach techniques that reach all segments of society. Assess the effectiveness of processes already in place. Again, measure, evaluate, and assess what exists and how to improve upon it. Conduct an analysis of the current advertisements used. Where are you recruiting from? What does your job descriptions read? Are you competitive, and are you attractive and appropriate to all of the different communities in which you serve? Identify what differentiates diverse job seeker career decision making, but deliver a consistent message and align your recruitment campaigns with organizational goals. Use competitive benchmarking. Monitor your audience response. Measure the results. Show you mean what you say. Find out what job seekers are looking for and tailor your message to increase response rates. And be careful not to use images that may send the wrong message. Assuming you are able to recruit, and I'm assuming that everyone will be successful in that attempt, then what comes next is making sure that you retain those talented individuals that you have been able to acquire and hire. So to walk the talk, to demonstrate by doing, to realize that diversity needs to be woven into all aspects of an organization and does not, cannot just be acknowledged in a of the month celebration. Follow through. Follow up on introductions to the community that you make during the recruiting phase. Orient the employee to the community. Support the employee's efforts to obtain housing, register children for school, find employment for spouses, etc. Mentoring. Ensure that there's mentoring throughout an organization. Designate mentors. And find out how to connect those organizations. And you can mentor forward and in reverse. Junior members of the staff can help mentor new executives as they come in to help them understand which way, how the organization looks like from the bottom up. Professional development. Support upward mobility. Provide staff training. Engage employees through open lines of communication, avoid tokenism, and be open to new points of view, respecting different experiences, and involving all of the staff. A resource that could be helpful in the recruitment and retainment as well as in the development of a diversity and inclusion plan is this effort from the HHS Office of Minority Health, the National Standards for Culturally and Linguistically Appropriate Services in Health and Healthcare. There is a document that goes along with these 15 standards. It's called A Blueprint for Advancing and Sustaining Class Policy and Practice, and talks about a lot of the techniques and practices that I've discussed here today, but does so in even more detail. It also provides additional context setting and other areas of ways to improve or adapt and adopt culturally and linguistically appropriate services. If you have any questions that we don't get to today at the end of the call, you can contact me at my email address, darci_graves@sra.com. The National Class Standards and the Blueprint are available at the www.thinkculturalhealth.hhs.gov website. I thank you all for your time and attention today, and with that, I will ask that we transition the slides over to Zara.
So thank you so much for having me present today. I always like to give an example of how at a grassroots level in the community one can start if you don't already have cultural diverse programs. I won't spend a lot of time on the definitions, as I think Darci covered them real well. I'll just give you examples of the different areas in which we have been able to, I think, really be effective and create innovative programs for the community by being culturally competent, which we know is different than being culturally sensitive. Sensitive means being aware of it. Competent means not only being aware of it, but the services that you're delivering in the community are absolutely linguistically and culturally appropriate and effective, which means you need to have people from those target populations delivering the service or being part of the team. So let me go ahead and give some brief descriptions here. Let's see. Okay, so the first thing is about our mission, and basically we started up in 1986 with 12,000 students. We were all teachers of English as a second language, vocational training. We had a licensed preschool. We had family literacy, lots of really cool programs, and that was under La Maestra Amnesty Center. We also provided application assistance for those that qualified to be permanent residents, which went on to do citizenship. We work with migrant workers in the fields, the seasonal agricultural workers that rotated with the crops and had provisional permits, to lots of different countries that had, you know, specific, whether it was emergency kinds of residency that then would expire and so forth. Everybody had their own issues, and so through these 12,000 students, 9,000 became permanent residents, and they basically integrated into our communities, and they said, hey, we need health care. And we thought, well, that can't be too hard. We'll just go ahead and add on to this wonderful program, you know, a few doctors, starting with pediatricians, and then added the OBGYNs, and then here we go. So that's kind of what we started in 1990, and since then, if you go to the next slide, which we'll get to in a minute, the annual number of patients that we are doing, we're seeing right now is about, at the end of 2012, was about 44,570 patients. We have numerous sites, well, I should say about 8, 9 sites. We do medical, dental, mental health, and soon I'll show you our circle of care of all of the other services that are not necessarily directly medical services, but we know that they are involved in the wellness of a family, of a person, and so that's why we've added them on during the years, because those same populations have told us, hey, this is what we need. We saw the trends, and those were kind of the gaps. Those are social determinants of health. So we see here the annual number of patients, and then we get to the next one, which is the visits. There you go. So the visits was 177,000. Probably will hit for sure 200,000 at the end of the 2013 because of the other satellites and the mobile clinics that we've added on and the other services. Next slide is innovative models at La Maestra that we've been able to really work very well with our populations. And one is the circle of care that you'll see on the next slide, and that's the integration of services. The second one is the medically trained cultural liaison model. We knew when we started these programs back in, well, under the Amnesty Center in 1986, that if we wanted to effectively serve and learn about what the needs were and the gaps that were there of different diverse communities, populations, or cultures, we needed to hire from within. Now, that's not always possible. You can't always find, you know, a licensed provider from Somalia or a, you know, medical assistant from Sudan. So what we did, and I'll give you examples later of how we actually started those, building those training programs from within. Then another innovative model is the electronic and cloud-based program case management in our circle of care. We have our electronic health records next-gen program, which manages all of our medical functions. And we have our pharmacy software, and then, of course, the dental, which is Dentrix. But these other non-medical services that we're going to talk about that are very connected to healthcare and wellness are being managed through this cloud-based program that seems to be working pretty well. We're expanding it now to our 4th line of business. Then we also have innovative digital imaging services. We're the first clinic in California that has brought mammography, full field mammography, digital mammography into our community health center, and that joins the ultrasounds that we offer, x-rays, and DEXA scans, and how we work through our cultural liaisons to make sure that we are effective in targeting, welcoming, and serving all of the diverse cultures that we'll tell you in a minute who we serve. Then the real-time specialty care via telemedicine. This has been supremely successful in that we have the cultural liaisons working with the medical staff at whatever sites we're conducting this telemedicine, or it wouldn't work. Nobody would understand each other. We wouldn't be able to deliver the health education. We wouldn't be able to understand traditionally, culturally, what those patients' reservations might be about the care that's being prescribed or developed for them. Also, school-based mobile clinics. This is also super important. You know, I wanted to give an example here. One of our sister clinics that has been in business, oh man, 50 years or so, what they were doing when the Somali refugees first came is they would pull their big mobile clinic that had medical, they didn't have dental, but they would pull this to a health fair in the middle of where a lot of the Somalis at the time were living, maybe 2,000 Somali living in different pockets of low-income housing in San Diego, and they would put on a health fair, and with this huge white-looking truck or van, and they had a big sign up on top of it that said, "Free HIV testing, come on in." And then they wondered why nobody ever went in. And the answer, of course, is that, one, a lot of the Somalis, or all of them, when they were in their country, any vehicle that doesn't look like a car is usually owned by the government. Military, police are the government, and they saw many of their people being taken away in these, you know, these big military government vehicles. So the last thing they're going to do is go step in something they don't know, but it doesn't look like it's your neighbor's vehicle. It doesn't look like it's trusted. There was no signs for them in their language. They didn't have anybody outside to, you know, to talk about the different services. And also, they have, you know, they don't want anybody in their community to know that they're going in for testing, you know, of a disease, an STD, so forth. So it was not a sensitive marketing approach. And I always like to give that example because, you know, we as federally qualified health centers spend so much time and money delivering the message and doing prevention and health education and going out and doing outreach and just numerous collaborations. But if we don't pay attention to the message and the population that we are trying to help with the message, encourage to come for visits, then help them sign up, if we don't pay attention to the way the message is structured, delivered, and followed up, we might as well not do it. It's just not effective. So the next slide, please. So this is our circle of care. You can see by the, we've tried to group these in colors. The red is, you know, obviously all the medical, dental, and mental health, and behavioral health, and pharmacy, and imaging, and so forth. The green are all of our microcredit, that's economic development programs. And we have, you know, like support programs like legal advocacy services, which is blue, which basically affects anybody coming into any one of these services, and it's there to support them. Eligibility and enrollment, transportation, translation, and interpretation. I put that there as a petal, even though what integrates all of these services in the circle of care is the fact that we have, you know, we have that cultural competency, and, you know, our hope is that whatever service we roll out, that level of cultural competency will be built in it already as a core. Chronic disease management, if you take that one, it's the orange one up there. I mean, we wouldn't be able to do the referrals, work with people on case management, make sure that they go to their specialty, follow up with their care, their medication, and so forth, if we weren't culturally competent. Let me give you an example. Another example is, you know, with our HEDIS and, you know, all of our benchmark measures, patient-centered medical home that we're all supposed to be moving along with here. Sometimes it's difficult to get certain populations to you know, to come back or to follow up, or actually to come in and get tested for certain certain illnesses, diseases, so forth. An example is was with some of our Ethiopians. When they first started coming into San Diego, we did have cultural liaisons from Ethiopia, from the three main language and culture areas in Ethiopia. And they came over, and we didn't know that they thought, or their belief was, that the test for diabetes is what gives you the disease. So luckily, we have these cultural liaisons that basically educated us, which is what your cultural liaisons will do. They will educate your staff and not only on different belief systems, but needs and so forth. And it's really fascinating. But again, without that piece of knowledge, we would have been very ineffective in just copying one plan for one group and just dumping it there, you know, like a prototype that's going to be working with all cultures. That's a huge mistake, I think, that a lot of our healthcare partners make. Next slide, please. So cultural competency, we know Darci already covered this, except the point I wanted to point out, next slide please, is that another one of our goals was always to train as many people as we could from within those diverse cultures to be in the healthcare field, because the minute we would send our patients out for specialty or other services off-site, man, it was impossible for them to communicate with anybody, for them to be understood, even labor delivery at the hospital. We've done some orientation with staff, but you know, it's got to be a constant ongoing training with our partners out there. And because I think a lot of them really are not committed. A lot of our hospital partners over the years have not been serious with this. Even though it's mandated for cultural competency, they will say, yeah, you know, or the managed care plans, those are another partner that do not really have sufficient cultural diversity on staff. If they want to attract and serve these populations that they have defaulted onto them, then, you know, how are you going to explain the patient rights to a patient that you do not speak their language? And there's no way that they can call, you know, a language interpretation line for each one of these members. That's impossible to believe. And we see at the hospitals what ends up happening. They call somebody, which is usually one of our cultural liaisons, that's the patients or their families. They call their neighbor who happens to work here that they know already, that's been out in the community, that's respected, that, you know, that they can call at 2 o'clock in the morning and say, hey, I don't understand what these people are telling me. What is it that's wrong with my kid? So that's really how it's being done. And, you know, and of course, they're using their family members to interpret as well, which is, of course, not the most desirable situation. So it is to open the access for all populations. And if we go back, we don't have to go back on this, but if you can flip back to the circle of care, you know, the therapeutic transitional housing that we run, it's down in the kind of teal colored there on your screen. For us to, of course, this is now not dealing with a culture like a language culture, but yes, it's a culture, a societal culture, that we have people in our populations, in our communities that are in recovery. And we have programs for those folks. And the therapeutic transitional housing, we have got like 28 men right now, 30% are vets. So if we are wanting to be culturally competent with that, we would take the statistics, take the demographics, take everything of those populations, and make sure that we have people that are working in the program that are, for one, in recovery because they have to know what people go through to be able to gain their respect, and that is something that a lot of our partners out there that work prison reentry programs and so forth, you know, are the first to say that the effective workers are those that have graduated or are basically still in recovery. And those are the staff members, and then of course we make sure that 30% are vets. Okay, then we have to make sure that you know that our staff includes veterans in all of our job training programs that we send these residents to, and it's super important. So I just wanted to be able to give a different example about, you know, culture, or those that are reentering society directly from the jails, the prisons. Again, to be culturally competent, to be able to understand all of the challenges and the concerns that are foremost in the minds of these folks that are reentering society, and therefore we would be able to develop, you know, a program that hopefully works better than some of the other recovery programs out there that are not connected to these services or job training or medical services. And that's why we felt that this would be a great way to have more of our participants succeed. Next slide, please. Okay, jump forward, jump forward. Okay, this is what our staff it looks like. There's over 26 languages that are spoken by our staff every day. And even if the population speak English, they prefer to have important information like, you know, the medical information communicated to them in their language, their native language. So the staff, we talked about that. We talked about medically trained cultural liaisons. What we do is we identify, next slide, please. We take the cultural liaisons that we've been able to identify from within those cultures. These are some of the languages. Next slide, please. We talked, about some of this. You know, if you don't already have programs that you think are culturally competent, or that basically a component, an overlay, a core feature of your service delivery program, then, and you're trying to start now, I would definitely, you know, look at who the populations you serve, you know, who are they, get the demographics, do internal assessments in, you know, who you've served, who you're serving, and then look outside there in your community, in your catchment areas, and say, okay, who's out there then? Who is it that we're not serving but lives here in our area that could utilize our services? Next slide. Darci touched on this too, which was, you know, making sure that, you know, you have a top-down and bottom-up approach. Well, you know, I've seen so many programs, organizations that try to develop, because maybe their medical staff or somebody, you know, one of the counselors in their mental health units, you know, really believes in this, and then they go through all of this effort and they bring it forward, and the admin or the accounting people don't understand, and then they throw it out, you know, or they kind of sabotage it. So to really make it work with, I think, you know, the executive staff definitely need to know. You know, the ground level staff, the ones that come in contact with patients every day, they know already the need, because they probably are sitting there struggling, trying to communicate with people, and really wishing that they had somebody there that they could ask, hey, you know, why is this or why is that, to be able to overcome some of these hurdles. So they are totally easy converts, I think. But the upper levels, like the executive management, the CFOs, oftentimes are hesitant because, you know, gee, that means we got to hire on these other people. And I'm not going to say that, like with us, we don't we didn't sit down and say, okay, we're going to hire 27 different, medical assistants that speak these languages. It just evolved. It started off with our primary language base, which was, Spanish, and then it went to, some of the Indo-Chinese, and then the East Africans, and then the Middle Easterns, and now the Burmese, and there you go. So it's important to find out the facts about the populations that you're working with, especially if they qualify for specific payment sources, like refugees that are, depending on the state you're in, have specific timeline to be covered for medical, dental, mental health, child care, transportation services. After that finishes, then they could qualify for your regular Medicaid like everybody else does in your state. If, for example, like in California, if you have a minor living at home, a child dependent that's under the age of 18, then that could qualify you for Medi-Cal. So just finding those things out, to be prepared to make the case to the executive management that, you know what, this is not going to be a drain on our organization. This is going to add to the sustainability, not only, doing what's right from a humanitarian perspective, but if you need to bring in these other arguments, be prepared to make the case. Our organization will really be basically serving the people that need the assistance, and that is aligned with our mission. And by the way, these folks that that we intend to target here are and bring into our patient base, they have this payer source or that payer source. Now sometimes they don't have clear payer sources, and so it would depend on what your state or your county funding is for that, or your self-pay levels are for cash pay patients. Next slide. And some of the resistance that you might see is that, gee, it takes us longer to serve these patients because, they don't speak English, they're not totally literate, they have, it takes us longer, we have to work through a translator, interpreter, whatever. Well, that's the way it is. And to serve the populations, that's what we need to do. Some do present, doesn't matter what culture you're from, sometimes they present with numerous issues, and it's up to us to manage that patient flow the best way possible. Okay, so this is another suggestions on how to initiate, look for the resources, materials on health issues, education, and other languages that can be used even before the new staff is recruited. And sometimes you can find this information already through managed care plans that have put together information, different languages throughout, let's say if they're in other states. Some of the government agencies also might have it through HRSA. I always contacted the ethnic-based community organizations, faith-based organizations, to reach out and find these cultural liaisons, and these usually were the ones that had worked in the refugee camps that got trained, or they self-trained, or some of the doctors trained them there, and they were always well known within their communities as the people to go to if they needed help, and if they needed medical help or whatever it was. They trusted them. And these people were seen to be very neutral. They didn't take sides with different political parties or different tribal factions. Next slide. And so what we did was then we look for these are some of the other suggestions. You look and see what your state's requirements are to be a medical assistant certificate, or a CNA, or dental assistant, front office worker, biller, health educator, so forth. And a lot of times you can find people that you can then train, and your medical director can then certify them after a year that they have worked in this position performing those job duties, and therefore they are X. So that's worked for us. Not all the time, but most of the time. And also look for other physicians from other countries, from those different groups that would be able to or would want to help us with health education and referrals, because these areas do not require certifications through the state of California. And as physicians in other countries, they understand the importance of their job in health and in how it relates to the whole health management and treatment of that patient. Next page. Okay, following up, mentoring them, Darci covered that. New recruits, to make sure that the rest of the populations or the rest of the staff in your organization understand these staff members are not here temporarily. These folks are going to be here forever. This is our culture. This is our organizational culture. This is what it looks like, and it's with these folks that you've added. So next page. I think that's it. Okay, so training, one of the other things is that, anytime we bring on new people, as you know, especially if we're bringing people in from a whole new population, whether it's the prison reentry folks that need health care, or what other services you're going to offer, or it's the veterans, or it's the refugees or immigrants, or whatever, you need to make sure to have people from those populations working with you, outreach, health education, and all different other kinds of jobs, and keep training and training and training, and do that mentoring and deal with, cross-cultural misunderstandings, so that the supervisors who've never worked with other populations or other cultures, don't misinterpret certain body language or nonverbal communication as negative. And so that involves doing orientation with the rest of the staff as well. So anyway, this is just fascinating. Like Darci said, we could talk about this for days. But if you all have any questions, please let me know. Don't hesitate to contact me. I'll be happy to share what we have with you. Thank you.
Thank you, Darci and Zara, for these wonderful presentations. And if you have any questions for our presenters, please either ask the presenter a question, please submit it through the question box on your control panel, or if you are dialed in through your telephone and would like to ask the presenter a question, use the raise hand icon on your control panel, and your line will be unmuted. Now, I have a question, and I think that Zara, this question is for you. What is the best way to reach out to your communities when you need a person in your organization that is part of the community that you serve?
Sure, Dr. Leon.
Yes.
We just had an example of this. We just had an influx of we had 1,000 Burmese families settled here in our area, and now we heard that another 1,500 are going to be settled by the new year. So one of the, when the Burmese first came into San Diego and were settled here, or they came through secondary migration, what happened was they showed up to the clinic, and a few of them, they didn't speak any English at all. Some of our staff that had been, that were from Laos, that had been in refugee camps for years in Thailand, who learned to speak Thai, were able to communicate with the Burmese, because the Burmese also were in refugee camps in Thailand and spoke Thai. So this was fascinating. So anyway, through them and those connections, we went to the temples, we went to the to some of the ethnic-based organizations that they call themselves Karen, and the Karen organization started up, and we found them and we talked to them, and they said, hey, you know, this is what's happening. These are some of the major health issues that we know and we've self-identified as a community, you know, issues with alcoholism, alcohol abuse, gambling abuse, all kinds of gambling addictions. And so we really want to do health education in our, you know, community health, community centers, and if there's some way that we can collaborate to address some of these concerns with you. And we said, sure, but we need to know from your community, can you recommend other people that could come and help us with these programs and with our general medical programs? Because we already have two Burmese that, you know, one was a nurse from the refugee camps. Burmese was there for like 10 years until she was able to come to the United States. And she, of course, had that reputation back home, and so that's how we found her, because she was the one helping them come in when they were first trying to access care. And so we identified her, and then we talked with the community, the temples, the schools, and that's how we found these folks.
Thank you, Zara. We have a question for Darci. Darci, you mentioned providing attractive services. Can you expand on that comment?
Well, making sure that I think that was in reference to when you are advertising for particular positions within your organizations, making sure that the description that you write up is attractive and appropriate for a wide, for the widest possible group audience. As Zara has so aptly described, you know, you will have numerous communities within your service area. Some of them who will be refugees, some of them who will be individuals coming out of treatment or coming out of prison or coming out of military service. You know, you'll have all of these different groups. So making sure that any materials that you develop that advertise your organization, the incentives that you may be using in order to recruit individuals, making sure that those are appropriate and attractive to a wide, to the widest possible band of individuals, and not just something that might be of interest to a particular niche or to a singular group. And as with everything, the way you determine what resonates across the board is through focus groups, is through connections, is through making those contacts and making and opening up those conversations and dialogues with the various communities that you serve and that you hope to serve within your community.
Thank you, Darci. I think that we have time for 2 more questions. There is a question for Zara. Zara, how do you recruit individuals to become medically trained, cultural licensed, and how do you support them?
Yeah, what we do is we start with the cultural liaisons, as I've described how we get them involved. And they kind of self-identify through their communities and you know, meeting with the different community leaders or church-based groups. And then you get the cultural liaisons, and you talk to them about, you know, what are you interested in? Are you interested in working with medical, dental, mental health? Did you ever help in the camps, or did you ever have any experience? Let's say you weren't refugees. Did you ever have any experience working in community service? That to us seems to be a better filter than just asking specifically medical, because maybe they were working for years with, with children that had disabilities. And then you say medical, and they're not going to say, yeah, that's what I was doing. And then it's easy to train them and put them through a training program that you could have, or work with your adult schools that are close by. A lot of times they have these certification programs that are for free. And it just so happened that we had programs that we worked with these adult educators, and then they brought over teachers, and that's how we started our curriculum. We have our own curriculum now that is for medical assistants, CNAs, dental assistants, and recently the support staff for mental health. And that's, it's wonderful. I wish we could do more of these certification programs, but it works with us in our state of California that our medical director will say, okay, Alex has been working as a medical assistant here for the last year, performing the duties of a medical assistant, and I therefore, certify him. And that has worked. It stood up to audits for us.
Thank you, Zara. And there is one more question for, this is for both of you. If you cannot find qualified, diverse staff, what do you suggest for recruiting? What are techniques?
I think in part the answer that I just gave addresses that, because with us we couldn't find people that were certified from these different refugee groups. They hadn't been here long enough. So we helped train them, find them training them in-house, and then looking for other programs that they could attend while they were working with us.
Great. Thank you very much, Darci and Zara, for this wonderful presentation. I want to thank you one more time. We need people like you to keep us abreast on topics like this one on how to recruit and retain culturally competent staff. I would like to share some resources for our attendees. The first one is from the American Journal of Preventive Medicine. That is, they have a publication entitled Culturally Competent Healthcare Systems. We have the standards published by the Office of Minority Health. Those are the national standards for culturally and linguistically appropriate services in healthcare. That's the full report. The Think Cultural Health website also has the summary of the national standards. And there are two more resources for the attendees. One, the very first one is the from the Maternal and Child Health Bureau. That is the promising practices for the recruitment and retention of culturally diverse students and faculty into maternal and child health training programs. And there is one more from the Office of Statewide Health Planning and Development in California. That is the Cultural and Linguistic Appropriate Services Resource Toolkit. To all of our attendees, please complete the post survey. This helps the National Center for Health and Public Housing to improve its webinars. And if you have any questions or if you have any training and technical assistance needs, please contact any of our staff members. Once again, we thank you very much for attending this webinar, and thank you to Darci and Zara for this wonderful presentation.
Thank you, Dr. Leon, for the opportunity to present to you and your constituents. It's greatly appreciated.
Thank you very much.
Likewise. Thank you. Thank you.
Thank you, and have a good afternoon.